Thank you for joining our webinar this afternoon. I'm Caitlin Crossley from Optimity Advisors, and I'll be your moderator. Dr. Niamh Lennox-Chhugani will be presenting. This webinar is about an introduction to a new way of working. Before Niamh starts, I'd like to introduce today's speaker, explain how to ask a question using GoToWebinar, and finally, how to access the webinar recording. Niamh is a managing consultant at Optimity Advisors and has 25 years of experience at senior levels in health provision, commissioning, policy making, and research internationally, providing thought leadership, experience and expertise to clients in the UK, Europe, Africa, and Asia. Niamh specializes in strategic delivery and of innovative models of care across organizational boundaries and real-world implementation of public sector policies. Today's webinar, an introduction to a new way of working, is the first of a series of webinars we will be hosting on health and transformation. Before we get started, I wanted to mention that we welcome your questions throughout the webinar. All you need to do is type yours into the question window, which for some is the 6th blue bar down on the GoToWebinar control panel, and hit submit. We'll get to as many questions as we can during the Q&A session after the main presentation. Finally, we're recording today's webinar and we'll post it on the Optimity Advisors website. We'll send you an email once it's up in case you want to watch it again or forward it along to a colleague. Without further ado, I'd like to turn the program over to Niamh.
Thank you, Caitlin, and welcome everybody to today's webinar. We'll start off today's webinar with a very brief context setting and explore how our world is transforming, why health and care needs to transform, and how we can accelerate this transformation by understanding how ready we are as individuals, teams, organizations, and whole systems. We will then introduce a validated framework which guides complex transformations built on sustained behavior change. This is one we've used in health and care systems over the last 18 months. This framework will be the basis of our future webinars. We'll be talking today about health and care systems. The reason for this is a growing recognition that separating health from personal or social care has had many unintended consequences, both in terms of cost and quality. Personalisation of health and care has been an increasing trend internationally, recognising that customers of health and care are demanding a different, more joined-up experience. Our work at Optimity as Advisors reflects this integrated whole systems approach to health and care in the UK and our work in the US. Globally, we see health and care systems set up to manage ill health. This made sense in the 20th century when we were still dealing with high levels of mortality and morbidity due to infectious disease and the impact of industrialization. Together with public health investments, such as large-scale immunization and screening programs, health systems have contributed to healthier, longer living and more affluent populations globally. Now, however, in the 21st century, we need a different response to the health and care challenges of a wealthier population living for longer in relatively better health overall, but with increasing inequalities and changing health and well-being needs relating to lifestyle choices and age. Our appetite for innovation in the 20th century is infinite, but our resources are not. Daniel Kraft, a doctor and medical innovations expert in the US, notes that progress and innovation in healthcare is showing exponential growth, resulting in increasing cost inflation. Combined with changing demand, this is not sustainable where we have finite resources. So decisions need to be made about how we allocate and prioritize in a fair and transparent way. Many innovators and policymakers are assuming the greater investment in technology and medical innovation will result in better outcomes and value for money in the longer term. Whilst the evidence of history tells us this will be true for some innovations, it will not be true for all, and the return on investment is not always clear nor clearly measured. So we have to manage a constant balancing act as we prioritise spending where we think there will be highest impact. Looking at the health and care system information, managers sitting in health and care providers are being bombarded with large volumes of complex information from within their own organisations, from policymakers, from regulators, and from other sources, including the media. They're under pressure to synthesize and act on this information quickly and make timely, accurate decisions based on this synthesized evidence. The traditional hierarchical structure of health and care providers places massive pressure on a few individuals to process this information. Is it any wonder that the turnover of healthcare leaders is so high? A study last year by the American College of Healthcare Executives reported that the turnover rate is increasing to between 18 to 20% per annum due to, and I quote, the increasing demands on chief executives to lead in a complex and rapidly changing environment. Here in the UK, a King's Fund report in 2014 highlighted that, and I quote again, almost 1/3 of all trusts had at least one vacancy or an interim executive board member. There is a crisis in leadership due in no small part to excessive information. This exponential growth is also reflected in the amount of information that we all have to process about health and well-being as consumers. As consumers, we're being asked to take more responsibility for managing our own health and well-being, both in terms of staying healthy, as well as self-caring and managing our treatment for less urgent or critical illnesses. We are moving away from relying on health professionals as the sole sources of expertise and information about health. More empowered consumers are placing different demands on health professionals, who are still being trained in ways that assume a traditional approach to healthcare. We must not forget, though, that there are still large numbers of consumers, particularly older people, who like the traditional ways of working with health professionals. They value the time that health professionals spend to build relationships based on trust and continuity. It's fair to say, however, that 20 years of process engineering and operational efficiency have tried to remove much of what was good about traditionalism: time and care. The way in which we interact as consumers with practically every other service in our lives has transformed in the last 25 years. The employees of these services are doing a very different job from the ones their predecessors were doing back in 1990. Think for a moment about how we bank today. How many of us have been anywhere near a branch in recent months, other than to the ATM? How many of us know someone who has worked as a teller in a bank? This change is coming to health and care too. If we get it right, it will give us, as consumers, the tools we need to stay healthy for longer. And when we are unwell or vulnerable and needing support, free up health and care workers to give us the time, support, and compassion we need to get better faster. This means a transformational change for every single one of us, including as consumers. Part of this transformation will be a shift from talking about patients and talking instead about consumers, citizens, or service users. You will have noticed that I've not used the word patient until now. This in itself is reflective of the kind of transformation we need to see from a system where the traditional roles of patient, in inverted commas, is clearly defined, to a system which recognizes the whole person and the active role they play in their health and well-being and that of those around them. So the transformation opportunity facing all health and care systems across the world is to give us as citizens or consumers better health outcomes, living longer, healthier lives, better experience of health and care services when we need them, and value for money as payers, either through taxes or insurance premiums in the context of a more connected, complex, and exponential world. We've all attended many conferences, seminars, read numerous policy papers, articles, and even books telling us about the high-level challenges facing health and care today. Some telling us why we've seen relatively little change. We know there are good examples out there of what works, but we struggle to understand what this means for our system and organizations, and for the consumers we serve at the front line. Translating strategy into practice has always been the biggest challenge for health and care professionals delivering care. Put this together with unrelenting pressure to cut costs, reporting on multiple dashboards, all essentially asking for the same thing, but each in a slightly different format or with a different emphasis, work with increasingly unhappy peers and or consumers. And we can see why the demand to transform feels like just another piece of noise. But we can change all of this. To achieve more than incremental improvement of what we already do, at its core is about inspiring a change of behaviours for health and care professionals and consumers. A change which most are hungry for and would readily embrace if released from some of the processes we've placed upon them layer upon layer over the years. That's not to minimise the importance of structure and process, but these should be mechanisms that enable people to behave in ways that deliver the things that matter to consumers. There's no one answer for this. This series explores some of the possible answers that can inform our implementation of the how. A great first step is spending some time really listening to what it is that consumers and health and care professionals want, and in a different way from the usual approaches to consultation we take. But more of that in webinar 2. First, let's define the health and care system that we're talking about today. It is the network of formal and informal organizations that contribute to an individual's health and well-being. It is therefore much more than health and care providers. It can include family, friends, faith groups, charities, a multiplicity of other social actors who support us all to stay healthy and well and support us when we're vulnerable. Social prescribing, which is increasingly common in the UK and US, is a good example of a mechanism that embraces this concept. To make a system work requires collaboration across organizational boundaries or traditional organizational or professional silos. It's about harnessing the collective intelligence of organizations and all that is positive about health, social services, and the charities' cultures of care and compassion to effect change, as well as the collective technical knowledge that they all have in diagnosing, treating, and supporting consumers of health and care and their families. This relies on system leadership. That is, a collective leadership from across the system that can clearly articulate an ambition and purpose that resonates with everyone involved and helps them see a better future. An NHS NIHR funded study as part of the Health Services and Delivery Research Programme reported back in August 2015 that there were links between health and care system characteristics, changes in unplanned admissions for people aged 85 years and over. The study found that sites with improving admission rates, that is, reducing admission rates for this age group, reported that they had a shared and comprehensive strategy for managing unplanned care and stable and clear whole system leadership. It's about enabling people to learn and improve what they do day in, day out, with leaders supporting and encouraging them to hold each other to account. Leaders who create an environment where health and care professionals and consumers are enabled to work together collaboratively, determine their priorities, and test out new ways of working that are centred around the delivery of high-quality care, perform far better in terms of quality, safety, and in turn value for money. Examples that have recently been highlighted include the South Central Foundation in Alaska, or NUCA Health System, Buurtzorg Home Care in the Netherlands, and Macmillan's one-to-one support for cancer survivors in the UK. But how do you get to this utopian vision? Well, chances are you already have elements in your own system. At Optimity, we talk about 5 disciplines and 3 mechanisms for making this new way of working happen. What Rod Collins, our Director of Innovation, calls wiki management. Together, these disciplines and approaches characterize the most innovative and high-performing organizations in the world today, including in health and care. Our wiki management approach leads us to a new ways of working framework that we will explore in more detail in future webinars. This framework enables organizations to rapidly collaborate around shared goals, aligned to their whole health and care system vision and strategy. It provides them with the capacity and capability to accelerate innovation by learning from failure as much as success, by experimenting in a controlled and rigorous way and embedding real culture change. This is a cycle, not a linear process, and will happen at different paces for different parts of the system, with complex relationships emerging between each component. This framework acts as a checklist and provides a set of actors within a health and care system with a profile of where they have strengths to build upon and gaps to fill in their transformation journey. The first quadrant of ambition and motivation is a prerequisite for the design. This continues to evolve and refine throughout the transformation journey. It is the blueprint for the new way of working and needs to be able to articulate what it looks and feels like for the consumer and for health and care workers working across the system more collaboratively. It's not a top-down process, but centred instead around the consumer. We will be exploring this in more detail in our next webinar.
Great, thank you so much, Niamh. We've received some great questions so far. As a reminder, if you have a question you'd like to submit, there is still time. Just type your question into the GoToWebinar panel on the right-hand side of your screen. The first question we have for you, Niamh, is you've talked about the importance of system leadership, but in practice, how does this work?
That's a really good question. I think if I think about it, there are 2 slightly different answers to that question. So one context I can think of is what I would describe as an easier context rather than an easy one. And this easier context, which we have experience of supporting systems with, is where they have a good history of working relationships. There's lots of continuity across the system in terms of leadership, positive experiences of joint commissioning and provider development. But what I would say in our experience is things get harder when leaders start talking about money, start talking about population risk and risk related to service utilization, whether they start having conversations about things like gain sharing in a new model of care, and what needs to change in practice. So how frontline practices might need to change, for example, for general practitioners. Good system leaders recognize this. They're prepared to weather the storm and support the people they need to support to have these difficult conversations and see it through these difficulties. The other context I would describe is much harder, and that's not uncommon in health and care, where relationships are weaker, there's a lot of turnover, or they've historically been damaged by perhaps experiences in the past, negative experiences of collaborative working. And in that instance, our experience is a significant amount of time needs to be invested by the leadership to build those relationships up again. A colleague of ours, Professor David Wellborn, who we work with quite extensively in this sort of area, talks a lot about cooking the conflict. And by that he means using the conflict very constructively to surface some of the assumptions that people are making that might be shared or might be in conflict, but have open and honest discussions about how that conflict can be resolved and worked through. The one lesson I think that we've learned is all of this potential mistrust needs to be surfaced early on in the process. If you don't surface it early on, you won't know where it is and you won't know how to manage it later on. It also sends a very strong signal to everybody else who's working in and across the system that the leadership have the confidence and capability to have difficult discussions and see them through. And that gives them the confidence and capability to do the same at a micro level.
Great, thanks, Niamh. The next question was asked at the beginning of the PowerPoint and when you were talking about empowerment, and the question from the audience is, how are we measuring empowerment, or do you have any examples of how that can be measured?
Are we talking about empowerment of service users? My assumption, so I'll answer that as if it's service users, but I think there's also another question around empowerment of staff. So is there a way of measuring? Yes, there are ways of measuring both. Most of those ways are quantitative, so we're all aware of the use of surveys across wide groups. We have also used focus groups extensively. Our experience, as many of you will know, our roots are in research and evaluation. So we have approaches to using focus groups where we bring together representative groups of service users together to explore specific questions. So yes, there are ways of measuring empowerment, but I think that the question raises an interesting issue, which is how do we interpret that word, empowerment, and what do we mean by empowered service users, citizens, and consumers in healthcare? And I think having, again, a discussion among system leaders early on in their journey to a new way of working, to share a definition of what they mean by empowerment is absolutely critical. I think also reaching out to service users and consumers and understanding to what extent do they want to be empowered is a critical part of our approach, and we will discuss that in a lot more detail in the second webinar. The other issue is around empowerment of health and care professionals themselves. One of the points that we make throughout these series of webinars is the hierarchical structures that health and care professionals are used to working within, and the professional silos that many of them have been trained within and continue to work within are not always conducive to empowered working. And by empowered working, I mean self-management, self-organizing, understanding, using your clinical judgment and your professional judgment to make decisions about priorities, but doing so collaboratively and in a shared way with the consumer or service user that you're working with. That is something that I think is probably the biggest cultural shift and the biggest challenge to us. We will be talking about some of the examples of where we've seen that addressed successfully by organizations, particularly in webinar 3, but also in webinar 2, where we talk a lot about how we help organizations learn from failure as well as success.
Okay, Thanks, Niamh. The next question is, how does this all relate to new models of care?
It's really interesting because when we originally talked about presenting these webinars, the focus was going to be on the 5-year forward view and new models of care delivery. But as we go through the next 3 webinars, you'll see that some of our examples are taken from vanguards and fast followers, but they're also taken from accountable care organizations in the US, from patient-centered medical homes in the US, as well as international examples where we've worked in Europe and where we've worked in developing economies. So our sense was that this is much wider than just new models of care currently being developed. And the framework that we're going to be talking through gives health and care systems a framework to design, test, learn and iterate how new models of integrated care or any other model that they might be developing, for example, the use of telemedicine, that relies on working outside of your traditional organizational boundaries or professional paradigms. It's a really helpful way of thinking about any transformational change, whether it's a new model of care that's come from the 5-year forward view or not. So I think all of what we're talking about here applies to new models of care in the 5-year forward view, but it is much wider than that and can be applied much more widely and outside health and social care, if I'm honest, as well. So hopefully the examples that we will use throughout the other webinars will help people to see that too.
Fantastic. Thanks, Niamh. Great. Well, we run out of time today, unfortunately. If we didn't get to your question, feel free to email us and we will follow up with you directly. As a reminder, we're recording today's webinar and we'll post it on the Optimity Advisors website. As requested by an audience member today, we will also post the references and examples Niamh used throughout her PowerPoint today. This webinar is one of a series, as Niamh mentioned, which is also running in parallel with our healthcare evaluation webinar series. The next webinar on transformation is on the 10th of February at 12:30, where we'll be discussing ambition and motivation. Why are we doing what we are doing? If you have any colleagues who think might be interested in this topic, please feel free to forward the webinar invite. Thanks again for joining us, and we hope you'll be back at the next Optimity Advisors webinar. Thank you.